Meeting to order. Install this meeting to order. Okay.
Sorry. Clerk will please take a silent roll call to determine no quorum being present. We will move our approval of minutes to a later time if people show up. The first item on the agenda is an update on the reorganization of the DHHR with the interim secretaries and the current secretary, Sherry Young, interim secretary for Human Services, Dr. Cynthia Presley, incoming secretary for Department of Health Facilities, and Health Services, and Mike Russo, Department of Health Facility. You guys would approach the podium down there. I think that will. Well, is there a light? Can they see down there? Is there a light?
But then you're not going to be able to see.
Oh, that's fine. Yeah, okay.
Good afternoon.
Good afternoon. Do you swear that the testimony you will give shall be the truth, the whole truth, and nothing but the truth, nothing but that?
I do.
I want to let the committee know that we will be getting an update on the transition, but also if you have other questions or concerns of things that have been brought up in the public in the last month or so, we'll be able to address those during this meeting as well. All right, please go ahead.
Happy to. Thank you, Madam Chairman, and members of the Locker Committee. Try to. That'll work. All right, thank you guys very much. So I wanted to start with giving an update on where we are with the Department of Health as we start digging into our different programs and different things that we are trying to make improvements between the split. So with the Bureau for Public Health, obviously that is the biggest bureau within the Department of Health. One thing that we've talked about before in locker meetings is that we have about 171 FTE vacancies within the Bureau for Public Health, and really trying to understand what we can do to address those vacancies and what the best way forward is. So the first thing we collectively did, we sat down with OHRM, which identified the vacancies that had been open the longest, some of them up to 2 years. Trying to look through, would it be easier to get rid of 50 vacancies and create new jobs and create new programs out of that and reallocate the resources? But we took a little bit of a different track. So what we're doing within the Bureau for Public Health is starting from the commissioner and state health officer level, working our way down through the deputy commissioners and getting all the way down into the programmatic folks, and really understanding where those vacancies are and what needs to be done to keep them filled. This week, we sat down with the director of the Maternal, Child, and Family Health Services, which operates under Title V funding, this federal funding given to the Bureau for Public Health to make an impact on several different programs, very critical programs that deal from everything from birth to death in the public health arena for our West Virginia citizens. With that, we were able to identify several vacancies within those programs and offices. And of course, when we look at having the 171 vacancies, going through and looking to say, a lot of these are nurses, a lot of these are social workers. These are people that need to be at the table for public health. So coming back and looking at what issues have we seen? Is it being able to maintain these folks? Is it geography? So with one of our programs for children with chronic illnesses, we looked at re-advertising and making sure that we could try to recruit additional nurses and social workers. But do we need the number of vacancies? Should we roll some of those positions up so that we get a stronger base instead of leaving the vacancies for such a long period of time? But also looking at maybe some of these things don't need to be regional any longer because it is harder to fill positions, not only across the state, but in several areas as well. With that, we've talked about other programs under the CFH, and happy to find great working folks. We have a nurse who's been working with one of our programs. I believe she's in the children with chronic illnesses. She's been with the state for 46 and a half years. You can't buy that kind of dedication. And so I'm so appreciative to her and to our folks that have been able to maintain that level of service for so long. Within the Bureau for Public Health, we've looked at several other programs that we need to keep moving forward. One of them, the Birth to 3 program. Birth to 3 is an essential program that identifies at-risk children at birth that need services such as speech language pathology, occupational therapy, physical therapy, and that early intervention gives them a better chance at doing better at school and being able to participate and having better outcomes overall. One of the things that we did promise as the new Department of Health is that we're going to look at outcomes. And so looking at these programs, some of these things have been under our nose the entire time. So when we look at Birth to 3, improving their value, there's no doubt that there's a value in treating kids and giving these services in the home for these children. But the outcomes are right there. So we're looking at going through, we have with our occupational therapists, our physical therapists, let's take a look at how much better these children are from the start to the finishing up of that program. In fact, there's other states that expand that out from birth to 5. Maybe that's something that if we can prove these outcomes are good, that we can continue to expand the programs and get kids across that finish line as they are trying to get to school for these early interventions. We also noticed a lot of vacancies within the breast and cervical cancer screening program. Of course, we don't have the best rates for screening of breast or cervical cancer in the state. Things that we are trying to look outside of the box to get that number to prove the outcomes moving forward is working with some of our MCO partners. And again, thank you, Helpline, for hosting here today. But we have looked at what would it be like if the incentives that they offer for women at risk and who have Medicaid to get their mammogram, what if we acted as that intermediary to try to get them connected either to a physician to get that referral? Is that the missing piece? Or to make sure that they get that incentive or understand that that can be incentivized, because sometimes these incentives can be used for transportation or other means to get folks in. Similar studies have been done. We did this at the Vandalia Health Network with wonderful outcomes. And so we're hoping that this will get our breast cancer early intervention and screening rates up for our folks in the state of West Virginia. So while we're talking about the existing FTEs and openings and trying to condense things down to make things more efficient moving forward, one of the vulnerabilities that we have, not only do we have the vacancies currently, but if you look at our workforce, we are 49 days away from the new year. We are 49 days from being 3 separate distinct departments, and we are hard at work trying to make this work for the state of West Virginia. 2024 sounds a long way away. Again, it's not. 2029 sounds like it also very far away. However, it's not. In 5 years and 49 days, if you hit the button on how many vacancies we could potentially have, or how many of our employees that are currently filling vacancies, for our workforce within the current DHHR structure, we have 53% that will be eligible for retirement in 2029. So if you take the fact that we have these existing FTEs that are difficult to fill, and then imagine 5 years from now, 53% of those people retiring and going home, you're going to lose the institutional knowledge of the folks, our nurses that have been there for 40 years. You're going to lose that institutional knowledge of programs and how to make things work. So we owe it to our citizens of West Virginia to make sure that we get the most efficient programs, but that we are backfilling and making sure that we are getting young folks and West Virginia folks in there to serve these programs now, because we have that additional vulnerability later on. I can't imagine if we cut 50%, 53% off today. We couldn't get the work done. So we have some time. That's the good news. But that is a critical piece moving forward to make sure that we have the people to deliver the programs so that we can continue to function in the state of West Virginia. In the Bureau for Public Health, we are also working on invoicing, and I did include in the packets a couple of different ways that we have looked at invoicing processing. There was a study done between January and July that looked at the current grant processes and what that looks like, and I included those in the slides. We do have a lot of work to do. So a few of the things to help until we can cut out some of the individual processes or cut back on an extra step or two to get things to folks a little bit sooner. Both with the OCME or the Chief Medical Examiner's Office and within BPH, we are trying to go that extra step that when we have people apply for the AFA process to get a grant, that we make sure that we have all of their information as accurate as we can. No, that's what the auditor's office is there for, to pick up any anomalies. But if we do have any anomalies, meaning that if it's the end of your business is an incorporated, but it doesn't match what the invoice doesn't match what the grant processes is, it can be kicked out. And that's to detect fraud. It's a much needed thing. But we on the front end are trying to help folks by making sure that they get all of that correct information in. In fact, not jumping from BPH to OCME, but one of the things that we've tried to do that we identified holding up the processes, we have to have, for body transports, for example, we have to have proof that they have insurance. You never know, even with a decedent, you never know what can happen from point A to point B. But we have to make sure that they have the proper insurance to make those transports. Every year, Director Izzo will make a packet out to each of those contracts and to the funeral directors. And we try to include as much information as we can. I'll go through some of the other processes that we're trying to tighten up to get those payments out to people in a timely fashion.
Dr. Young, I hate to interrupt, but since we got started late, it's 1:25. We want to hear all three presentations by 2 o'clock. So I know you have to hurry up your time a little bit. And then from 2 to 2:30, we want the committee to be able to ask questions.
Absolutely. I will keep moving on then.
Okay.
But I'm sorry, I do get excited about the good work that our folks are doing, and I will continue to move on. So with Office of Emergency Management Services, some things coming out in the news. Cabell County currently is using whole blood in the field for EMS, which, as you know, from healthcare it can be life-saving. That is a big deal. We are looking to make the policies and put the policies in place that we could, as West Virginia, be one of the first states or the first state to provide whole blood in the field. And that couldn't be more proud of the work that they're doing, the certifications and everything going very well with OEMS. Also watching those emergency department wait times, making sure that everything's flowing and that we can get those trucks and those providers to folks as timely as we can. For the Office of the Chief Medical Examiner, again, I'll go back to the invoicing piece. We are reaching out to the Funeral Directors Association. Again, after the last OPERA meeting, we were informed that Mr. Kynes, unfortunately, is stepping down from his presidency from that association. So working with Chief O.B. Thaxton from Elkview, who has been in that role before, considered to be a good friend and a community leader. We're looking at working with him and looking at other opportunities to help with the body transport process. It's not something that is budgeted, so it is difficult, but we need to make sure that we're good partners on both sides. And so we will be reaching out to do additional programming with them and to make sure that they have all the information they need. Jumping down to the Center for Threat Preparedness, always good to be prepared. So we are dusting off old plans such as the Ebola virus action plan, other action plans for uncertainties. We are working with our emergency managers and Secretary Cersei as far as trying to figure out our medical piece with the emergency managers if anything would happen, including bioterrorism. Office of the Inspector General, I believe there's a page in your packet that summarizes the great work they are doing there. They are caught up 100% on all of their requested reviews for OFLAC. That's something that hasn't been done in 11 years. So a huge thank you to that group for getting that work done. I do have to give some of that credit to our OHRM folks who went and helped get their needs and to assess what vacancies and help them for the recruiting process. But it's good teamwork to help support them in those efforts. For that, I will, in the interest of time, I am just going to share these grant invoicing processes with you. This is from the 828 Foundation. We recently discovered that there was another evaluation of the process about 2018 when Dr. Gupta was the state health officer, that they were looking at what the process invoicing would look like potentially from BPH. And that was, I think, in an effort to get some state accreditation for, national accreditation for the state health department. We're going to try to put the two plans together and see if, even if we can cut out a couple of days or some of the redundancy. But as you can see, I couldn't explain that in less than 5 minutes if I tried. So I will spare everybody with these two.
And
for
it's in
right
our
now.
packet.
It is in your packet. From the 828 study, this was the recommendations that they made. I will leave those with you. Those are things that we're trying to put in process as we speak, trying to make it a little bit more, make the process of reviewing the grants and reviewing vendor payments a little bit more streamlined as we go forward. So I do catch a typo on number 7, so I do apologize for that. With that, I will pause and see if there's any questions before the rest of our group.
Questions for Dr. Young? Delegate Fehrenbach.
Thank you, Madam Chairman. Dr. Young, you mentioned, I guess, your projections or possible projections on retirement at 53%, within the next 5 years and 49 days could be retirement eligible.
Yes.
Do you know what the current experience is for your employees? How many of them actually retire, like, shortly after they become retirement eligible?
I can see if OHRM can pull that data. Yes.
My experience is that, yes, there's a day with the experience and age that happens, but then workers may stay around longer. And so to kind of understand when they're eligible versus when they currently leave, I think would be interesting to kind of incorporate that into your, if you will, attrition planning and hiring needs with that regard.
Absolutely. So this is a vulnerability because they will be eligible, 53% of them within the 5 years and 49 days. But if we cannot collect that information on the front end of how soon after most people are eligible do they retire, it's not a bad question to go ahead and ask folks upon retirement eligibility, do you plan to stay? It's our goal to make it a place where people want to stay. I'm going to actively seek out our nurse who has been with us for 46 years. I can't wait to meet her because I want to know what we have been doing right in her book. So yes, I will get that information to you.
Yeah, I would be curious about that because then the projections on staffing need to be reflective of that actually.
Yes, thank you.
Thank you.
I have a question. So you brought up the Center for Threat Preparedness, and without getting into the details of the federal indictment on that, since the former director was having some issues, do you think we're going to have to pay back the 35 to 45 million that's in question there? And if so, where would that come from?
That would be part of the investigation and something far beyond what I'd be comfortable with answering at this time.
Okay.
We do know that. Oh, sorry.
Well, let's just say, and the way you set up the structure, I know during COVID they brought that office up to be under the secretary. So is that going back to where it used to be?
Given all the circumstances, I feel more comfortable with that office being able to report directly to me so that we can make sure that we're reviewing these processes and making sure that everyone's well cared for. Again, Center for Threat Prep, they do have a very critical role. So if everyone's in agreement, I prefer that they go ahead and report directly.
To you. So you don't think that was part of the potential failure because we skipped a lot of the processes below, right? That, like you're talking about the grant processes and all that. You don't think that hindered that?
Looking at the volume that they had to take care of, it really was survival mode. I mean, you went from processing a few hundred grants or accounts payable within a month to several thousand. So there's a lot of vulnerabilities there that I think we need to look at moving forward, saying these are the processes to follow. We want to make it more efficient, but we want to be able, probably staffing wise would be if we could find more accountants and nurses, I think we would have a great chance at improving the Department of Health for good. But if we could have those efficiencies and that ability to not rush things through and keep those processes in place, that would be a good plan for moving forward.
Are you going to maintain that joint interagency task force, or is that going to go away?
The Joint Interagency Task Force, we're looking at a couple of different options. Obviously, COVID pandemic, the public health emergency is over, but it is a good opportunity for collaboration because you have a lot of folks at the table that could help with looking at social determinants of health. So if you think about the GIADF as being a convener, getting people together where we can look at things like by county. What are the needs in each individual county? If we're looking at a local health department or a DHHR office where they're written services, not all of our services meet the complete needs of the patient or of our public. So if you have someone who needs SNAP benefits, but they qualify, but that doesn't feed their family and friends quite thoroughly, or they have trouble getting to transportation to and from a grocery store, they have food needs or housing insecurity. We're looking at the concept of if they were a convener, how could we pull all of these folks and resources together so that when they come to the Department of Health or the Human Resources offices, that we can hand it and say, if these are your needs, then here's some of the ways that we can help you. So the function of the GIADF, no, we don't have that need anymore. But that is one thing that's maybe good to look at.
It would also be great if you eliminated it if it wasn't necessary from a government's perspective. So, any other questions? Okay, next presenter.
Good afternoon.
Thank you, Dr. Percy, for being
Thank
here.
you. Thank you for having me, and thank you to the health plan for hosting us today. I'm going to give you some updates from, I'm sorry.
We'll swear you in.
Yeah.
We need to swear you in.
Oh,
Sorry, it's hard to hear.
sorry.
Do you swear to tell the truth, the whole truth, and nothing but the truth? Okay, thank you very much.
Thank you. So once again, thank you for having us. I'm going to provide you with some updates on the transition to the Department of Human Services. And I have a lot of content on the slides, which you have in front of you. So as you know, if we get short on time, I won't go through all of the content on the slides. So just like Secretary Young indicated, we have these are the bureaus and the offices under the Department of Human Services. Just as a reminder, the Bureau for Medical Services, which was where Medicaid and CHIP live, Family Assistance, TANF, SNAP, major programs like LEAP, Bureau for Behavioral Health, Bureau for Social Services, which is where Adult Protective Services and Child Protective Services live, and then Bureau for Child Support Enforcement. The name is self-explanatory. And then finally, the Office of Drug Control Policy. I wanted to give you an idea of what we've been doing across these bureaus since in the short 4 months since we have joined in July of 2023. And this is a list. I'm going to go through each of these just to give you a flavor of what we've been doing in terms of processes and in terms of increasing efficiency and effectiveness. So the first, very similar to what Dr. Young talked about, is the evaluation of all the vacant positions and really evaluating them for continued need. Is this a position that we are planning to fill? Do we need to fill it? Is there a way that we can use our resources more widely and wisely? Then evaluation of all contracts for impact and continued need, same thing for grants, and then evaluation of our facilities. So I'm going to talk first about the vacant position review. In our first round, we identified about 40 positions that are deemed no longer necessary within the various bureaus in the department. We will continue to be looking at positions each time someone leaves, before we advertise, before we start to fill a position, using the same criteria. Is this a position we continue to need? Is there funding available for the position? Is there a better way to do the work? The budget request that you'll see in the legislative session will include using a portion of those funds that are being saved by those 40 positions to provide salary increases in particular classifications. But we know, of course, that's certainly up to you and your decisions about the future budget. But key initiatives that are ongoing that will be important in decreasing the number of employees include, first of all, a very clear delineation of responsibilities, which goes into our evaluation of processes, and really being clear about what our processes look like across the entire department. Technology investment, and so using technology more wisely than we have in the past. I've been astounded by the number of things we do by hand at DHHR, and then efficiencies, as I mentioned earlier. We've also been undertaking contract review. And so this is currently ongoing. We have completed a review of all contracts that we have in place with external organizations, and looking at them for whether they're meeting the scope of work that was designated in the contract, whether they are doing that in an efficient way, and could the work be handled better in a different way internally at a lower cost? What are the ways that we can be more efficient with our contracts? The same thing with grants. And our grant review has been really focused on measuring the impact of the work that we do. So we have just completed, each bureau has completed an analysis of the outcomes of their major grant funded programs. These grants are typically grants that we are providing either pass-through dollars for the federal government or legislatively appointed dollars or appropriated dollars, and we are passing them through to partners to do specific work on our behalf. What I asked the bureaus to do was to reflect the actual difference their programs are making. So I want to know what the impact of these programs are, that observable result of the work that's being done by the partners. And I don't want merely head counts of how many people we've served. I will say, and don't tell our federal partners, but our federal partners require us to do a lot of head counting. And so a lot of the data that they require from us is how many people were served, how many doses of naloxone did we give, how many, whereas I'm more interested, and I think we as a body should be more interested in what is the impact of that work on the people that we serve. And so if we're talking about how many doses of naloxone, for instance, was there then a subsequent reduction in overdoses? I think that the process of going through these reviews and looking at outcomes was very enlightening to our bureaus, in that a lot of the times they are doing head counts and they are not taking the next step to make sure that we receive the data or that we collect the data that indicates the impact of our programs on people. So I gave you some examples of things that we're interested in. If we're doing a program where we're providing transitional housing for people who are leaving our state hospitals, for instance, did that result in fewer hospitalizations? Did it result in fewer emergency room visits? Those are the kind of data I think we need to be looking at. We need to be really focused on in order to evaluate our services. So the current status of that project is that as of November 1st, all of our bureaus have completed their reviews, and some of our bureaus have many grants. So this has been quite an undertaking. I and my deputies are undertaking the review of all of that data. And then we will be developing with the bureaus work plans for improvements to those impact analyses. So what kind of data do you need to collect, or are we already collecting, that we can put together to look at your program outcomes? So for instance, We, in our Bureau for Behavioral Health on Save a Life Day in West Virginia, we gave out about 25,000 doses of naloxone. Well, our Office of Drug Control Policy follows overdose rates. So our Bureau for Behavioral Health and our Office of Drug Control Policy share data so that we can look at, in the subsequent 2 or 3 months after we gave out 25,000 doses of naloxone, did our overdose rates start to drop? So those are the kinds of data sharing or transitions in data analysis that we need to do in order to really know what the impact is that we're having. The Bureau for Family Assistance has already developed a work plan that they will implement between now and December to really train their staff up on fiscal accountability for these grants, on statement of work development that includes very clear outcomes and grantee oversight and assessment. They've had a lot of turnover, so they have a lot of new people who are doing this work. They will also be looking at redesigning drafts of their statements of work and programs that they put out for proposals each year. They will be causing everyone to develop SMART goals and to demonstrate that accountability to impact. The last one on the list is evaluation of facilities. So over the last 4 months since I've been in this position, I received a number of reports about poor conditions of some of the facilities where Department of Human Services staff work and where our clients visit for vital services. So operations staff in September undertook an analysis of all of the state-owned properties they are continuing to do an analysis. They're always doing an analysis of rental properties for county offices. The result of the analysis of state-owned facilities was shared immediately with the Secretary for the Department of Administration and the Governor's Office. And in particular, I just want to use as an example our Raleigh County DHHR office. Located in downtown Beckley. When I visited that, I found it to be wholly unacceptable for our employees to work there and for us to bring clients in for services. It was dirty. It had mold. It had carpets that had not been changed in 30 years despite a number of floods. And it was just wholly unacceptable for our employees and our clients. So upon reporting that to the Department of Administration, they immediately deployed a team. I think I was there on a Thursday. On Monday, they had a team there to evaluate and has begun work to remedy the situation, pulling out carpets, painting, renewing a look at the housekeeping contract. So really trying to bring that building up to standards. We've done the same thing with the Diamond Building, which is where a number of our program staff work in downtown Charleston, and toured that building with the DOA staff and really looked at some of the unacceptable areas in that building as well, and they've begun that work too. One facility that has been on my mind is the West Virginia Children's Home, which is a non-secure residential facility for children ages 12 to 18 in Elkins. It has a very small census since COVID, since the pandemic. But I was urged to visit that site to really look at that facility. It is a historic property. It was built in 1909, and it is in clear need for attention. The current status of the evaluation of that property is that we did put out an RFQ for evaluation and what needs to happen to bring that up to current code. We did award the contract to identify what those improvements need to be so that we can look at whether or not this is a budget that is something that is available for us to continue occupancy under current code. We have a kickoff meeting on site with the vendor this week, and they have promised that we will have the evaluation of the property along with a plan within 75 days. That property at that 75 days will bring us into legislative session, and so I will be able to present you with an update at that time. But we want a safe facility for children who are homed there during that portion of their residential treatment residential stay. It is not a treatment facility per se. Any treatment that they receive is outside of the facility. We were asked to also talk about the number one priority for the secretaries. Choosing my number one priority was like choosing between my children. And so I opted to give you more than you asked for, and basically providing you with the specific priorities for each bureau. This is obviously, there is much more work going on in each of the bureaus than is reflected here. But these are the priorities over the next quarter to 6 months. So for the Bureau for Medical Services, the Medicaid unwind, which completes in April, to really result in stabilization of our census on Medicaid, rate setting rollouts. We've been doing a lot of work with rate setting, and then the managed care RFQ, which will occur in December to increase perhaps the number of MCOs who participate. Bureau for Family Assistance, full implementation of the family support centers, which I talked to you about previously, which are really focused on prevention, and then SNAP, TANF, and the utility assistance support, including additional outreach for those programs, especially for populations who have been hard to reach. I'm aware of the time, so I won't go through each of these, but to tell you, just to pick out some highlights of things that you've probably heard before, youth residential program model and rate restructure for the Bureau for Social Services. That's been ongoing, working with providers on a new model for residential care since August of 2022, and they meet monthly. They released some of the initial rates for one of the levels of care to the provider group last Monday at a meeting. We continue to meet with the providers monthly and holding weekly office hours with providers so that they can talk through the new model and the rate restructure. Child welfare transformation. One of the things that we want to really do is improve our decision-making model support for case assignment once cases are accepted. And that is, we have been evaluating a number of software systems and have settled on one that will be a much more robust system for decision-making model, a more robust decision-making model for case assignment, improving time to first contact, and of course, continuing workforce recruitment, retention, and support. The last thing I'll say is the Office of Drug Control Policy will be rolling out their 2024 strategic plan after completion of their statewide focus groups. They have completed those groups and they are working on the draft strategic plan. They will be presenting that to us as well as to the Governor's Advisory Council on SUD. And I'll stop there and ask if there are any questions or want to hold them till the end.
Questions for Dr. Person? Delegate Berenbach.
Thank you, Madam Chair. First of all, I want to thank you for your analysis and some of the examples that you shared. On a couple of topics like the outcomes, I'm fully supportive of things besides the activities. On the facility you mentioned in Elkin, the children's home, were there any life safety issues that needed to be addressed, or were there other issues with that facility?
So that will really come out, I believe, in our analysis. But I can tell you that from the surface, me looking as a non-expert, it is not ADA compliant. Our bedrooms and bathrooms are on different floors than the main floor. There is a ramp to get into the facility. However, there is not handicap accessibility. It is a non-secure facility. However, bedrooms are up onto the 3rd floor and windows are old and these are teenage boys. And so I am concerned about the safety issues related to old windows on 3rd floors of buildings. There are a number of exposed pipes throughout the building, old building, especially in the basement, but in the basement is also where, for instance, laundry facilities are, some of the showers, and some of the recreation areas. And so I believe, yes, there will be life safety issues. Whether or not they violate current residential code will be what we want to really look at.
Encourage you to give that. due
Yeah,
diligence and-
absolutely. So I can sleep
Speed.
at night.
Yes, thank you.
Questions for Dr.? Okay, I will.
Thank you.
When you're talking about the children's home, how many, oh, sorry.
That's okay. Never mind. It's hard to hear up here.
How many children are at the children's home?
Currently, I believe there are 5 children there.
There are 5
They have a
children.
capacity for 12, but there are currently 5 children.
We're not required to run that as a state, are we? I mean, I know we own the building, but
Well, there is some state code that might indicate that we are required to run an orphanage, which is an old word, and these children are not orphans. So there is some old language in the code, but it can be interpreted in a number of different ways.
and that seems like something we might want to look at further. I mean, 5 children and it's really old, so I'm sure it's a
Right.
very expensive place. And
Yeah.
is there anywhere else to put these 5 children?
Excuse me?
Is there any other facility where we can transfer these 5 children?
Well, the 5 children are court ordered to that particular facility, so our intention would be to work with the judge in that area.
Okay. And when you talked about the residential
Yes.
program, and I know they're changing that model, some of the providers are concerned, the level 1 and 2 providers.
Mhm.
Is there any possibility of introducing the higher level and phasing out the 1 and 2 slower? Or are we going to just do this all at once?
There is no plan to phase out any level of care.
Okay.
This plan is designed so that the level of care follows the child and not the facility. And so, for instance, if a child needed level 3 care at any particular time, the program would be reimbursed at a level 3 rate, which includes treatment and therapy, as well as room and board and the other components of the rate that you've heard about. But as the child becomes better and better and is getting toward discharge, we expect to see that level of care that that child needs come down. And so then the rate will come down. It's very similar to the way that we that Medicaid restructured SUD payment in the past with the different levels of care. Many of you remember level 1, level 2, level 3, level 3.5. Our health plan friends are shaking their head. They know that very well. So that level follows the person. And so we can progressively provide that child with the best possible care at the level in which they need. We need to do better for these children. We can't have children in a level 3 facility for 9 months, for instance, without a discharge plan. And so there is no intention to close any beds. We can't afford to close any beds. We have 540 beds in the state. We need every single one of them. The change is a change in the model of care to an evidence-based model that will allow for the rate and the level of care to follow the child.
You mentioned IT issues and a lot of things being done manually. And so we need to get up to the 21st century, perhaps in state government. Can you talk to us, because we've heard these issues about corrections and we know that the state's facing the Better Childhood lawsuit. And we know about the evidence with corrections, and we had that same issue with the HHR. So was a hold on the evidence and the litigation done in the way that it was supposed to be done?
Yeah.
And if there's been a problem with evidence being retained, is there any correlation with us changing from Microsoft to Google?
I would not be able to answer that question about the change to Microsoft Google. However, I can answer the first part, and that is that for every time that we receive a litigation hold for a lawsuit, we follow the appropriate process, and litigation holds were filed with the Office of Technology. Unbeknownst to us, they did have a policy that when someone left the organization, that they decommissioned or deleted their emails. We are working very closely with them on making sure that we have systems in place and processes in place to prevent that from ever happening again. But we did follow the process that's been in place for over 40 years. And that is that litigation holds were sent to the Office of Technology and that's where we are.
Okay, thank you. One last, go ahead. Go ahead, Senator Woodruff. Question.
Thank you. Going back to the level 1, 2, and 3 children, are you anticipating them all being in the same facility?
So a number of so that will be worked out at a residential treatment facility by residential treatment facility, because some of them, for instance, are in cabins, smaller homes within the larger property. And so a program may opt to have all of their level 3 children in one area and their level 1 and 2 children in another area. In some cases, they may be in the same facility, depending on safety and things like that. So that's really going to be worked out facility by facility in that model of care.
Thank you.
Delegate Tommy.
Thank you. Thank you, Dr. Persley, for being with us again. This goes back to the litigation holds.
Yes.
Are you aware of any other cases that process may impact, like the lack of following through with the process and deleting of, I guess, those accounts impact for the DHHR in the future? Is there other pending litigation that may be a factor?
So there is at least one other, I believe, pending litigation for which there were litigation holds that we know of, that may be impacted
And in the
beyond a better child.
And in the past, has that ever happened before, like with any of the other lawsuits that have been settled or that have been adjudicated?
I couldn't answer that question. Our counsel, April Robertson, who's been with the department for a number of years, is here and may be able to. I see she said no, so.
Thank you.
Mhm.
Other questions? I have one last question.
Okay.
This has to do with CPS. And a lot of our constituents are talking about this and probably because of this case that's occurred in Sissonville and it's in everyone's mind, or the little child with the fentanyl on the carpet, a lot of these different issues that are happening. Are you seeing do you think there's CPS process breakdowns going on? I mean, are you evaluating that? Can you give us a little update on that so that
Sure,
we feel
absolutely.
confident in the process?
Yeah, so as I have reported in the last few meetings, we are, all of our bureaus are expected to have continuous quality improvement processes going on. And certainly CPS, APS, all of our bureaus have continuous quality improvement processes going on all the time. And so if there's a breakdown in a process, we are delving into what the breakdown in that process is. In the case of CPS, we instituted in August a process that is called Child Stat. I'm not sure that I've even ever reported on that before, if you've heard about it before, but Child Stat is a process by which twice a year, all of our regional offices must come together with the secretary, I was at the first one, so I guess you could say the secretary, but with the commissioner and the deputy commissioners, the supervisors and managers are all present, and they present their data on all of the important metrics that we have. For instance, time to first contact, cases that are closed within 30 days. And so they present all of their aggregate data. They also present what they've done to improve their rates, for instance, what has worked, what hasn't worked, what have they done that they feel that other regions may benefit from, and what would they never do again because it didn't make a difference. And so that process, like I said, just started in August. It was the first round. We did have baseline data, and we did see improvement in most of the regions in all of those metrics. I expect that the second 6 months we'll see even more improvement. But in the meantime, so I'm not saying that we only look at things every 6 months, but in the meantime, what we're doing is that continuous quality improvement process.
Okay, thank you very much.
Thank you.
Senator Deeds.
Thank you, Doctor, for being here today. Thank you. One follow-up question, if so CPS receives a report, and they have to investigate it, what is the turnaround time, roughly the turnaround time on those investigations?
Right, so the benchmark is that all investigations will be completed within 30 days. But there are different levels of complaints that require first contact within shorter periods of time. And that is based on the severity of the complaint. So I can provide you with the fact that about 60, and I don't want to misquote this, but it's somewhere around 68% of our investigations are closed within 30 days. However, or not closed, completed within 30 days. However, there's a number of reasons for them not being completed. So for instance, we may have trouble locating the family, which happens more often than we think. We may have been given bad information, and so it takes some days to find the correct address or the correct town. So that causes a delay. Sometimes those families are already involved with CPS, and so we find that there's already an open case for CPS, and we add that particular issue to that open case. So there are a number of reasons why the investigation may go longer than that 30 days. It also may be difficult to get people to speak with us to actually complete the investigation.
Just one follow-up
Yes.
with that. If it goes past the 30-day mark, is a supervisor automatically initiated?
So the supervisor automatically initiates weekly an update with each worker. And so they look at the open cases, and that's where they're looking at those benchmarks of have we completed by 48 hours or 72 hours or 1 week and are working to try and resolve those cases. And certainly if it goes beyond 30 days, they're working to resolve that as well. So the supervisors meet weekly with the CPS workers to assure that they're meeting benchmarks. And if they aren't, then there's a good reason for it.
Thank you.
Elegant Tom.
Thank you. And thank you again, Dr. Are you aware of any supervisors that are currently on suspension or have been terminated because they did not follow up within 30 days and there was a child harmed?
I'm not aware of that.
Thank you.
Thank you.
Next up, incoming Secretary herself for an update on health facilities transition.
I don't have a slide list, so it's in the
You swear to tell the truth, whole truth, and nothing but the truth, so help you God.
I do.
Thank you very much. Please proceed.
Okay, first of all, welcome to here. I'm from Philly, so I just want to welcome. Okay, thank you, give you your time. So briefly, and at a high level, our major objective for the health facility is to determine and develop a strategic plan for each of the hospital. Okay, we are on track. We are in the middle of the assessment process time period for those. We would, our assessment period should end in March. After March, actually should be mid-March. After March, what we'll do is start implementing what we decide to do in regards to the hospital. As you know, we have 7 hospitals, 511 long-term care beds, 310 psych beds, 55 acute care beds. Right, we have spent tremendous time on financial statements to make sure that we can take a look at our hospitals like the industry does. Second thing is we've done a lot of time on FTEs. We are in the mix of this since we met last month. We are adjusting probably over 200 FTEs. Some positions we're eliminating, some positions will drop on a contract staff, high-level contract staff cost to a lower contract staff cost, and the other ones will be reallocated between the departments in the hospitals. So that report that we initially shared with you, that will be readjusted, presented in a different time, all the adjustments that we made to the field positions, the vacant positions, and contracted positions. We struggle with contract staffing costs. We've spent a lot of time on that, and it's still very high from an expense. As you know, like based on the, um, few years back, I would want to say 2023, we started to go to contract staff, got into a situation where basically 70% like that was some of our hospitals. And then the hourly rate went for us and ours. Now what we've done is we've started to turn the curve, taking them back down to the, basically rebid the contract staffing contracts. We use about 30 contracts at this particular time to find the staffing. So number of things internally to try to make sure we stay a little bit competitive with our internal processes and our internal wages as you may know. The HRM, we're looking at wage adjustments, potentially looking at some changes internally. So with that said, I'll be there for any questions.
Questions for Secretary Pinto?
Yes, sir.
Thank you, Chair. Do you have any issues yet with the COVID situation?
We monitored it over currently. Of course, from the past, we did. Currently, we have a handful of our staff who monitor the COVID for both our patients and employees at all of our facilities. As of yesterday, we might have everyone that has COVID or has been tested positive, been managed very well. So that's it, but we don't have any major problems. You have some with COVID, we're managed. But on the patient side as well, we stop.
Do you have any travel nurses come in?
Oh, that have COVID?
No, just
Absolutely. We have a lot of travel nursing, and that's been our problem here recently. We worked with a company that did very well with us. And basically what we're doing with the travel nursing, we implemented an emergency travel nursing policy a while back. And that emergency travel policy just to get staff, so we didn't have to close bed, especially in our psychiatric facilities. Our hourly rate went up too high. Okay, so what we've done now is terminated over 100 of those contracts, and we dropped that level hourly rate back down. You have to go through this process in the state where we started at the bottom. We are concerned about the staffing by the end of the year, but we think it's the best thing for us to staff it best that we can. That answers your question. I'll get to take over.
thank you.
Delegate Robot.
Thank you, Madam Chair. And thank you for your attendance today. As you are kind of putting your plan together, is it some of it gonna, or is any of it an assessment of where we're at, just as far as the physical plants, 7 facilities are, and a master plan of how to go forward with modernization of these plans and a cost associated with that?
If you're question, yes, they're all great. We've also initiated that needs assessment for both psychiatric beds in the state of West Virginia and long-term care beds. The preliminary reports are we need additional long-term care beds, and then during that, when you look at that evaluation, it's actually determined by county in the state of West Virginia. So how many more beds do we need per county in West Virginia? That report is coming up now. The psychiatric bed is a little different because we have a methodology issue. Within the assessment that we're doing, first of all, we did a benchmark study to determine where we stood fiscally across a lot of metrics, which we would love to share at some point and continue to come back to you individually. We want solutions before we share that data. The second step is to do exactly that. Determine what it costs to stay in that building, what it costs to build a new building, and where there's other buildings where they should be from a physical plant standpoint. That's one of our biggest problems, physical plant. All our facilities are aged, okay? And then what we'll do is we'll do some financial modeling to determine what the best scenario is for us to go forward with the cost. Go forward with each of those particular individual options. Consolidating, eliminating, partnerships, or a number of different scenarios. We don't want to jump to the conclusions before we finish our list.
And is there a timeline of when this committee can expect to take receipt of that?
We will have the assessment done definitive on our schedule for March 14th.
And that will be comprehensive to all the three elements that I've talked.
Yes, it'll be comprehensive, yes. Now, it won't be implemented.
I
We plan on moving forward on
I understand, that's to be up, I'm sure there's gonna be funding needs that legislation has to talk. But, so you expect a comprehensive plan of where we're at with these physical plans, what our needs really are, and what our plan is to go forward. You expect that comprehensive report in March.
Yes, sir.
Okay, thank you.
Can you give us an update on Welch Hospital?
Yes, I can. As you all know, we've developed a relationship and made an announcement that we were going to have a partnership with Welch Hospital. Okay, initially, I think it was in January that they made the announcement that it was converted over to January. They bumped it over to March. We recently, as of last week, made a determination that we will not meet the March date. Okay, we are working through some transaction, fine legal terms, basically, in regards to making sure we know where we stand with Welch Hospital. So we made the announcement, talked to all our staff, talked to all the commissioners down there, and we told them that we would let them know what the thing schedule. WVU also said the same thing. Of course, they moved a little bit of equipment around because they are always on that ongoing process to implement the Epic system into so many other healthcare systems that they move some equipment from that. We believe, we feel very comfortable that relationship with WVU will be this is still very good, and that we will work through the contract terms, so we have to look. Part of that is the financial situation in regards to what expectations are. And that's one of the other reasons to do this assessment. We have internal and external counsel that comes in to perform these assessments. Want the financial advisor to come in and take a peek at that before we make a final determination. That answers your question.
Yes.
We did not put a date on the when we would come back to it.
Okay. Another question, can you just reassure the community that in the news, of course, you know, one of Sharp employees was arrested for murder. Can you just give us, our background checks done? Is this a contract worker or someone hired by the state? Can you just give us a little information on that?
Sure. You know, first of all, on Sharp seems to be in the news all the time.
Thank you.
Regarding that, we try to manage that process, and every time that something happens, we actually bring in outside people in to review it. So there was an article in the paper last week about a use case that showed pictures, terrible pictures that went in the newspaper. So we actually brought in an independent ombudsman in to come in and take a review of that case, and found that there were no findings. Someone pounds their head against the floor and the wall, and blood all over the picture. Someone takes a picture and then it leaks out some way. You know, we don't always get the truth, the whole story. All right. Now, Sharp is a complex hospital. It's like, yeah, facility, do have issues up there. We're going to continue to look at options to make sure our quality of care there is provided and done well, either through internal or external. Right into that.
Well, do your employees go through background checks?
Oh, yes, absolutely. So everybody's checked that particular incident, like a few others in regards, Sharp is probably one of our higher contracted staff facilities. I think it's in the 70% now. But everybody goes through a background check. There was no background issue with this individual that was a nurse that actually was there for a while. No problem whatsoever. I believe probably shouldn't jump to any conclusions, but I hear it's a domestic problem heard before, and they just happened to get her when she was working at Arkansas.
Okay. Further questions? Thank you,
Madam Chairman. Sir, I appreciate your being here. Your comments feel like you're on top of the whole situation. One of the things you didn't mention, but it would be an expectation that I'd like to ensure that is addressed in your plan, is your forecast capacity needs for the facilities that reflect the changing demographics in the state. So there may be, if you will, an upcoming peak in certain facilities, the need for beds, but as demographics change, say 10 or 20 years from now, what will that influence be? More or less numbers of beds and facilities, things like that, as you kind of look, into formulate the plan that we're going to need support for another generation or so.
In that needs assessment, which is done independently, we will have that. It's done by age and category and projection, okay? But I will tell you, we have 511 beds. We use about 200. Actually, we have about 190 patients today. There's a gap between what we use, what we have, what's the facilities from a facility structure standpoint. So, that was kind of a little detail, but the answer will be your answer to that.
Thank you, sir. Appreciate it.
Any further questions? Thank you. Secretary, y'all, if you don't mind. I'm going to ensure the over everyone at the moment. Thank you. For the one transition we haven't talked about, and maybe we can discuss this further next month, but is the Office of Shared Administration. And as I'm looking at the development of the departments, I worry that I just see sort of redundancy. When I look at the structures, I see the same offices in all the departments as we have in the Office of Shared Administration. So when I looked at the org chart for that, it has, MIS and personnel and all of the different categories. Something I would like for the secretaries to contemplate is perhaps this model isn't going to work in January. The last thing we want is, our goal in the legislation was to have all of those things at Office of Shared Services and then for the departments to utilize them. But I've heard in testimony from you all before is that you feel like you need those people in your departments that have specialty in those areas. Somebody knows about grants for foster care, or somebody knows something about grants for WIC. Different people have different specialties. So just something that before January comes, I would like for y'all to listen to West Virginia. If you would let us know if you think maybe our vision for that is incorrect, and perhaps the Office of Shared Services employees needs divided into the regular departments and we don't utilize that model, because we would have to change legislation by January.
I appreciate that. And, we have been hard at work trying to make sure that we follow the letter of the law and the intent. And there are some challenges with the shared administration. As far as having those departments within the shared administration, they all function very differently. And what's happened over time is that you have people who have developed this wonderful fund of knowledge that it's going to be hard to split in either fashion. So whether it would be, I'm going to use finance, and I'm going to pick on Tara a little bit because she's phenomenal and she takes care of all of us. And that's been the one great thing of coming there, that with 3 different secretaries, 3 different directions, those folks with OHRM, MIS, and finance, everyone has really embraced us and tried to make this transition very easy. But when you come to a point where you have someone who has that much institutional knowledge, it's hard to say it makes sense that, with more programs and federal funding that would live within the Department of Human Services.
Right.
But what would those MOUs look like? And we're very cognizant of the fact we want to be responsible. We want to minimize those FTEs the best that we can and not expand too much. Or not expand, but be able to get a greater reach with the resources that we do have. We're truly open to whatever will work, and maybe we can come back looking at each of those individual programs and how that may work, so that we can get this right from the start. Again, we work great together. I'm very lucky to have the 2 secretaries with me that I do and the staffing that we do, but we want it to be that if we all won the lottery tomorrow or something, so to speak, that we would all walk away and leave it a success for those folks coming in.
So perhaps next month, how many employees are in Office of Shared Services, and do you think there's a path forward if we wanted to transition them out to them? department.
Thank you. And if you don't mind, I will probably be in touch to discuss that so that we can be in lockstep.
Yes, that'd be, thank you, thank you. That's all I have. Oh, Delegate Hunt.
Thank you, Dr. Young, for being here. You mentioned the breast and cervical cancer screening program.
Yes.
And, we had talked about some of the modalities of how you get people in for screening. Lung cancer kills more people in West Virginia than colorectal, prostate, and breast cancer combined. That's statistically significant. But yet we limit the access the Lucas bus has to certain counties. So for these low-dose CT screenings for lung cancer, do you think repeal a certificate of need would be a viable way to get that bus into the counties to address some of those health disparities and provide access to those counties that are not getting those folks screened?
If that gets access into counties where folks can get the low-dose CT scans to prevent or for early detection, yes, we need to get that screened.
And I think it's worked well in Nicholas County because they are permitted to come into they actually come out and set up in our FQHC parking lot, and it provides access to a lot of patients to get screened that would not normally be screened. So I think that's another point. I was really surprised when I learned that they were limited by certificate of need.
Yeah, happy to look at that. And yes, the better we can get access into our rural counties that don't have a lot of access.
It's sometimes even if you have a hospital that does provide the screenings, getting the patient's transportation to the hospital, to get in and get them scheduled, that seems to be a lengthy process. This really streamlines how, and they're prior auth, and everything is arranged, whether they're insured, do not have insurance, where they're Medicaid, Medicare, whatever it matters. I mean, they get them prior auth before they get onto the bus, and it really kind of simplifies the process for patients.
It does. And so the better we can do with the early screening, things that we want to do moving forward too, and this is something that I'd be happy to champion through the Department of Health, is getting them to treatment. So, if you go into Nicholas County, and I'll pick on Wyoming County for just a second because that's where I grew up. But for Wyoming County, it's 45 minutes to get to a medical facility for any type of screening. You have great family docs, but of course they're not equipped to do these types of screenings. They don't have mammography centers or low-dose CT scanners for this. So if you go to where they are and identify the cancers, we want to help start that conversation of how to get them into treatment and make sure that they get the appropriate follow-up as well.
Thank you.
Sure.
2:25, we will be wrapping up our meeting. In your packets, there's draft legislation that we were going to pass out of committee today if we had a quorum. We do not, so please anticipate that for December. There is also the Mountain Health Promise Report, which collects data on West Virginia's specialized managed care program for children and youth in foster care or adoption assistance programs. You've got quarterly reports from the Governance Council, Medicaid report, Medicaid waiver report, CHIP report, Recovery Residence Task Force preliminary findings report. These are all in your packet review for the next meeting. Is there any other business to come before the committee? Chair looks to the co-chair for a motion.
Motion on adjournment.
Co-chair moves to adjourn. All in favor, say aye.
Aye.
No. The ayes have it. We are adjourned. Thank you very much.
Yeah.
Yeah.